Hi again, class. I am going to talk about now the meat and potatoes of what bases are decision making, evidence-based guidelines. So we're going to talk about that. So this is what sets us apart from being an RN to an advanced practice nurse. This is more like we're going into the medical model and we're diagnosing and we're treating based on evidence-based guidelines. You'll hear guidelines, evidence-based guidelines, clinical guidelines. There's terminology that intermingles with one another. So we're going to talk about briefly sensitivity and specificity, because that is one of the ways they come up with these guidelines doing their trials. Screening, and then we'll go through the United States Preventative Task Force guideline, and I'll talk about all the other organizations, institutes, societies, etc., that have their own guidelines, and then what we're going to focus on. Dr. Parvey talks about immunizations at a later week. So I'm going to click on the sensitivity and specificity here, and we're just going to go through it briefly. Dr. Parvey also has a lecture that goes into a little bit more depth, but this is pretty much what it is. So what is sensitivity? If a person has a disease, how often will the test be positive? So it's a true positive rate. So in another way, if the test is highly sensitive and the test results negative, you can be nearly certain that they don't have the disease. All right, so we'll talk about mammograms. I'll show you a sensitivity. So if it's negative, you can be nearly certain they don't have the disease. So that's sensitivity. It helps rule out disease. And how they come up with the sensitivity is equals the true positives. So they take the true positive plus the false negative and divide by the true positive, which gives you the sensitivity. All right, so that's sensitivity. Specificity. If a person does not have the disease, how often will the test be negative? So the true negative rate. All right, so we have true positive and true negative. In other terms, if the test result for a highly specific test is positive, you could be nearly certain that they actually have the disease. A very specific test rules in disease with a high degree of confidence. Specificity, rule in or spin. So that is the true negative plus the false positive divided by the true negatives gives a specificity. Okay, so true positive, true negative. Then we have these fun predictive values for positive results. So predictive value positive asks, if the test results positive, what's the probability that the patient actually has the disease? All right, so the higher, the more probability the patient has the disease. And the predictive value for negative, if the test results negative, what's the probability the patient does not have the disease? All right, so I'm going to go back to my slides, because this is really important on understanding what goes into making these guidelines. We take not me in particular, but these societies do research and they take samples of people. Most of the guidelines are based off of randomized control trials. So to go back for screening here, and testing for disease in an average or low risk asymptomatic population. So I'll use one example. If someone comes in and they need their screening mammogram, they're an average risk asymptomatic population. If someone comes in and feels a breast lump, I'm not going to send them for a screening mammogram. I'm going to send them for a diagnostic mammogram and ultrasound, because she's not at this point an average low risk. I have to assume that there may be something going on. So try to understand the difference between screening and then something diagnostic, something wrong. Screening is secondary prevention, because remember, we want to reduce morbidity and mortality. We want to catch things early. It's not primary prevention, because we're not preventing the disease. You can't prevent colon cancer from getting a colonoscopy. And how the guidelines go in, it's very high sensitivity, early detection, and then the ability to modify a course of disease. All right, so let's go into guidelines. This is a very busy slide, but I want you to see how confusing it can get on guidelines. So which ones do you follow? A lot of them have the same agreement on the guidelines. Some of them don't. If you look at these, for example, the most cancer societies Your more specialized ones, American College of Cardiology, are going to be a little more strict. All of these guidelines are based on randomized control trials done by different organizations or their own organizations, and they come up with reading the randomized control trial, sensitivity, specificity, determine what is the best recommendation overall for the entire population. So looking at all of these, what we're going to focus on in APN1, especially for secondary prevention and primary prevention, is the United States Preventative Task Force, the second one up there. When we start going into diabetes and cardiology, that's when we're bringing in guidelines from the American College of Endocrinology and the American Diabetes Association. When we talk about heart failure, we're using more the American College of Cardiology and the American Heart Association. But when we're talking about screening, immunizations, alcohol screening, depression screening, we're going to use the United States Preventative Task Force. So think health promotion, that is what you're going to use. Most organizations, or actually nationally, we should all be using the USPSTF. So there's two ways to get to it, the two links, but I do want to go over a couple things first, and then I'll go back to this slide to the United States Preventative Task Force.org. The other one above it is the AHRQ, and that's just another way that you can get to the guidelines. In that site, they have the National Guidelines Clearinghouse, so you can basically find any guideline in there. But I want to go straight to the site. But I want to show you exactly what ratings are. Every single guideline, depending on the organization, is going to have specific ratings based on what they've determined and why. It's just easy for us to be able to look at the letter and say, oh, it's a recommendation A, or it's a B, or it's an I. The Preventative Task Force recommendation A, that means that there's good evidence that it improves important health outcomes and concludes that the benefits outweigh the harms. Recommendation B, which we see a lot, is routinely provide to eligible patients found at least fair evidence that the service improves important health outcomes and concludes that the benefit outweigh the harms. So these are very important for you to know throughout your practice and starting now. C, there's no recommendation for or against. So we're not really sure. So the benefits and harms are too close to justify general recommendation. Recommendation D, they recommend against providing the service. And I, there's insufficient evidence to recommend for or against. So now that I went through all of these, and remember this is based on a population, in your practice you will run across people that remember treatment needs to be tailored. All right, so you take these into account, these recommendations, and you take them very seriously into account, but there could be an outlier that, say, someone, if it's a recommendation D, if someone's 78 and really wants a mammogram, even though it's not recommended at this point, you schedule them for a mammogram as long as, they know that maybe their insurance wouldn't pay for it, although insurance is pretty good at paying still for mammograms. So I'm going to use just breast cancer as an example, and then what I want you to do is I'll show you how to walk through on the Preventative Task Force guidelines, because they change. So to me, let's go to the primary source. I gave you a list at the end of the slides that I want you to know for the exam about what is recommended at what ages. So it would be nice if you made out a table that would help you study for that. So breast cancer, it's the leading cancer of women and the second leading cause of cancer death. And greater than 50%, there's no known major predictors, which is why mammogram is so important. The risk increases with age. And remember, we have BRCA1 and BRCA2 genes that contribute to that. And so that's really big right now is, I know you've heard out in the media, I forgot her name. I'm not really good keeping track of famous people, but there's been a couple famous people that are in movies that tested positive for BRCA1. I'm not sure about BRCA2, and they had a hysterectomy and a mastectomy. So that's a very personal decision. But BRCA1 is associated, though that's a gene, a genetic marker, to breast, ovary, colon, prostate, possibly male breast cancer. And BRCA2, we know, is strongly associated with breast cancer, ovarian cancer, and male breast cancer. There's a question mark whether it's associated with colon, prostate, and pancreatic cancer. So let's look now at the sensitivity and the specificity. So a true positive and true negative. So the sensitivity for mammography is 56 to 95%, which is high. It's lower if you are younger, have dense breasts, or you're on hormone replacement therapy, the sensitivity, because sometimes it's hard to see through the dense breasts, and just the younger population do better with ultrasounds. Specificity, there's more false positive in younger women, but the specificity is 94 to 97%. So if it's negative, it's most likely negative. If it's positive, the sensitivity, it's most likely positive, something going on. But again, remember, you always get that population where they're being called back for more films. That's okay. That's because we're taking extra precautions. If we see something abnormal on there, that ends up not being abnormal. So as you can see, as the ages go up, the rate of cancer goes up also. What's scary is that we always hear these younger women being diagnosed with breast cancer, but still overall, and probably the reason being is that we have social media, we have more news outlets now, and we're hearing about the younger crowd having breast cancer. Yes, it has risen as it had years ago, but again, overall, greater than 60 years old, there is a higher incidence of breast cancer. It's just not talked about as much as perhaps seeing a 20 or 30-year-old with breast cancer. That's devastating. Devastating for everybody. Now, this is to diagnose breast cancer based on a clinical breast exam. So you see the sensitivity goes down just a lot, actually. It's very important because remember, when you're getting a mammogram, it will be able to detect a very, very tiny mass in there compared to when you check your own breast. By the time you check your own breast and feel something, usually by the time you really can feel it, it's bigger than what the mammogram would show up. So most of these screening trials to come up with these guidelines are between ages 50 and 69. There's much weaker evidence in ages 40 to 49. This is for breast cancer. And then the interval screening we don't really know about. But over 70, we do know that it reduces life expectancy, and there's a really higher absolute risk of cancer. So mammography benefits increase with age, and the relative risk diminish with age. So the United States Preventative Services Task Force recommends screening mammography with or without a clinical breast exam every 1 to 2 years for women ages 40 and older. So that is a B recommendation, and I'll show you on the site. B recommendation. And if you look at other societies' guidelines, we're pretty much in line, although some of them will say yearly mammography. Insurance, we usually go along with the trend of every year. I do with my patients. I'm very much in early detection with breast cancer, and so I kind of do, the insurance pays for it and get one every year. The self-breast exam, if you can see, checking the breast yourself. So let me just get this straight. The one before was a clinical breast exam in the office, me checking for lumps. Now this is you doing it yourself. As you can see, the sensitivity goes way down because, again, by the time you find it, it's usually a lot bigger. Maybe it's been there a while. We don't really know the specificity. We don't know if there's a mortality difference at all. And the self-exam, so now it concludes that it's insufficient to recommend for or against. So it's an I recommendation. So again, what are you going to do now when you're in the office with these patients? So what I tell them is The American Cancer Society, they still recommend doing self-breast exams. I still believe it's an important adjunct with a mammogram and a clinical breast exam. So if you do all three, that's my recommendation. What I tell patients is to just get to know their breasts. You know, if you've never touched your boobs, how are you going to know what they feel like? If you know what they feel like, then if you feel them again, you're going to feel something that's not there that was there before. Sometimes our minds can play tricks on us, but that's okay. It's better to be safe than sorry. There's other considerations such as clinical judgment, patient preferences, and this is where the tailoring comes in individually with each patient, but I would never recommend against a mammogram. Family history, BRCA, gene, other organizations which I mentioned. So the AMA, American College of Gynecology, American Cancer Society, yearly after age 40. Yearly after age 50 is the American Academy of Family Physicians, and then it varies between 1 to 2 years, 1 year, 2 years between 40 and 49. Breast self-exams, all of these down here favor teaching. So these are the screening recommendations I want you to look up. So whether you want to make a table to try to help you, that would be good. That would be helpful if you guys are learn better by making tables. All right, so all of these, osteoporosis, aspirin, because these are all things that you're going to run into with primary care very frequently. So let's go back to the slide, and actually I'm going to write down here because we're going to look up a couple of these. Let's look up, I want to look up celiac disease, because it's interesting, right? Because you're seeing more and more people say, I don't know, I wonder if I have celiac. But is screening, what's screening supposed to be? Depression. And let's look up HIV. Okay, so I'm going to go back to my... Okay. Sorry if I'm looking at another screen. I got two screens here. And unfortunately, my big screen is the one I could see better, which is the other screen. Okay, so now you're on, we're on this website here, and if you look down, like these are new announcements, and to let you know when they're making or revising guidelines, there's always an opportunity for public comment. So you can make comments on these if you like and read through them. So everything is public. So when some people like disagree with guidelines, I mean, we can definitely take an active role and go on here and see where they're at in the guidelines and make comments if we want. This other part here is tools and resources for your practice. So this is what I recommend you do is there's the EPSS tool. There's actually a phone app for that, and you can actually like put in the age and whatever screening you're looking for, and it can tell you if it's recommended and what the grading is. So I recommend that. I don't really recommend this because things change so much. It's actually a downloadable book. And then you can just look into these. Now these, this here gives like case studies and questions that you can answer, some good articles. All right, so let's go back. Actually, we don't have to go back. The left-hand column always stays the same. So if you want to find out recommendations, you click on recommendations. These are frequently viewed topics. There's some recommendations in progress. We would do that. You can look up Affordable Care Act and what the recommendations are, etc. All right, but I want to search the site because I'm going to look up celiac. Let's see what comes up here. All right, so we know that this is screening, and this came out in 2017. Adolescent, adult, and pediatric, and it's published, meaning that this is the current recommended guidelines. All right, so this is the summary. So it's insufficient, so we really don't know if we should be screening people or not. There's current evidence is insufficient. So at this point, it's if someone comes in and is having symptoms for celiac disease, then you probably would say, yeah, okay, we can go ahead and test or send a GI if they're having the symptoms. But really, it's not, the recommendations are insufficient. So no, it doesn't give you a really good answer. But that's why I wanted to put that on there, so you can see sometimes there is insufficient evidence. Let's look up depression, which screening's been around for a long time. Okay, so we have depression in adults, children, adolescents. This came out in 2016. Let's look up depression in adults. All right, so B recommendation is good, which means that says that, yes, we should screen for depression, including pregnant postpartum women. It should be actually done at every visit. So if you want to read further into it, you click on that. All right, now we're going to look up HIV. Remember HIV, you had to have consent forms. Some people still think you do, and you don't. You don't need consent forms to screen for HIV. All right, so let's just see. There's no year here. This is 2013. Okay, this is non-pregnant adolescents and adults. That's in progress. Okay, so you see we have a 2013, so that's the one we're kind of going by right now, but as you can see, there's new guidelines in progress now, but they're just not published yet, as well as preventative medication. Let's click on what the current guidelines are. All right, so they recommend that clinicians screen for HIV, anybody ages 15 to 65. And younger adolescents and older adults who are at increased risk should be screened. So that is a grade A, so anybody ages 15 to 65 should be screened, as well as pregnant women should all be screened for HIV. They don't need a consent form, you can just draw it. One more I'm going to look up for you is colon cancer, because then you can see how there's all different recommendations and how each age group is different. So this was just published in 2016. All right, so they're actually trying to narrow down all of these. It used to be where there was like an A, C, and another category. So 50 to 75 recommends colorectal cancer screening, and then 76 to 85, it's a C recommendation. So they really, it's depending on their history and the patient's overall health. And it says here, specifically, if they've never been screened, they're more likely to benefit, and they'd be most appropriate among adults who are healthy enough to undergo it and don't have any significant comorbid conditions that limit their life expectancy. So if someone has end-stage emphysema or heart failure, do you really need a colonoscopy? So again, that's a conversation with them, and they probably would say that's okay, we don't have to do that. And I'm going to look up cervical cancer. All right, so now as you see, this one came out in 2012. It looks like a new one's being worked on right now. I don't know what those changes are going to be. Okay, here's a good example of seeing multiple recommendations. So we know for sure, it's a level that we know for sure that the benefits outweigh the risks. Anyone ages 21 to 65 or 30 to 65, you get combo HPV. So if you're 21 to 65, it recommends screening for cytology every 3 years. But if you're between ages of 30 and 65, you can do co-testing. So that means you check for HPV plus the cervical cytology. And then they can go every 5 years. Not all clinics have the HPV testing available, and they still just do every 3 years, but really they should get on the bandwagon because, and the reasoning, because most cervical cancers are from HPV. So if you're negative for HPV, it's highly unlikely that you're going to develop abnormal cells on your cervix, which is why now you can go every 5 years. Also, HPV is very slow growing. So that's why, say you have sexual intercourse at 15, we still don't recommend it till age 21, because most likely the cervical cells have not changed at that point, or just so slow growing that it's just not recommended. and then you can read these on your own, okay? All right, so I'm going to finish up with this. Take that one slide and go through it, look all of them up, do what you have to do, make notes, make a table, but this I really need you to know for your exam, and you need to know it for practice. You'll feel much more sufficient when you're seeing patients. Be like, hey, you need a mammogram, because what we want you to do is think critically. If you have a woman comes in who's 45 for her pap smear and mammogram, you need to know a lot of things, okay? First of all, if they're dating, do they need gonorrhea, chlamydia screening? Look that up. HPV, HIV, cervical cytology, mammogram. Do they need a mammogram? Do they have a family history of colon cancer? Then would they get it at age 45? So those are all things that you want to look up. Make up different scenarios for yourself. An 18-year-old girl, a 25-year-old boy. You know, that's what I'd like you to do, because that's what you're going to see on your exam. All right, that's it.